Hello, I'm Liz Lawrence. I'm a general internist and the Assistant Dean for Professional Well-Being. I'm here today to present the first part of two modules, the first module of two modules called Checking In on Mental Health. My hope, and the hope of my colleagues who helped develop these two modules, is that by the end of your engagement with these modules, you will feel more comfortable recognizing behaviors that medical students, residents, and physicians have when they're under psychological distress. That being able to identify these behaviors, you will feel empowered to reach out to a colleague to offer help and support, and that you'll be familiar with the resources that we have available here on campus. Depression, stress, anxiety, burnout are all extremely common. They all share common risk factors and all can manifest in similar ways. And so I am talking about them as having a commonality. I'm calling all of them psychological distress. I want to be respectful, however, that each condition has its own diagnosis, its own interventions, and can vary in severity from each of the other conditions. We're talking about psychological distress because we want to destigmatize it. It's very common in our profession, and yet there can still be shame attached to feeling like you're burned out, or shame attached to being depressed or anxious. There's that sense of, well, all my other colleagues are doing this. What's wrong with me? Or a sense of personal failing. We're all going to face times of distress in our training and in our practice, in our professional careers. And while I don't want to normalize it because I hope that we don't all encounter it, I do want to normalize seeking help and encouraging people to seek help. I also want to put the focus on systems, again, emphasizing that being under psychological distress is not a personal failing, that so often the burdens that are placed on us as physicians wear down any resources that we may have, internal resources. And ultimately, if we can take good care of ourselves and of our colleagues, we're going to improve the care that we provide to our patients. There are many factors that contribute to psychological distress in physicians. I'm sure you can write this slide just as well as I can. Obviously, excessive workload, an inefficient work environment, being sleep deprived, being hundreds of $1,000s in debt don't contribute to psychological wellness. But I want to emphasize that we are exposed to very personal, very high stakes moments in the lives of our patients. And we see death, we see trauma, we see illness, and that can be painful to process. And more significantly, when we feel that we've lost meaning in our work because we're feeling that we're only doing administrative work or documentation and not finding that connection with patients or not finding what it is that we are passionate about, we really can feel distressed. The model that we're using here locally and nationally to talk about professional fulfillment, and you could put psychological distress in the center of this model, or burnout, is that the systems, the institution in which we practice, the systems in which we practice, the culture in which we practice play a majority role in how we feel. Personal resilience is important. You certainly do have to take care of yourself, but that more than 2/3 of whether or not we're feeling burned out or overwhelmed, again, are related to these other two domains of culture of wellness, a culture of compassion, and efficiency of practice. How easy the workflow is, not even easy, but how efficient the workflow is in your work area. Some of the symptoms of distress that you will note in colleagues include sleep disturbances. Someone may be sleeping much more than usual or much less and may talk about how they haven't been able to sleep in weeks or sleep well in weeks. You may notice that they're quicker to anger, quicker to tears. Big sign to look out for is whether someone is withdrawing or isolating themselves, not showing up at social events, not engaging with their peers as they usually would. Significant changes in weight, either up or down, are signs of distress, as are a loss of confidence, cynicism, a change in performance, from going from a stellar resident to really seeming not to care about patients, talking about self-harm, using substances, using more alcohol, and just not being around as you expect that person to be. When you want to support your colleagues, you need to trust your observations. If you've seen the behaviors, not all of them, of course, but some of the behaviors that we talked about on the last slide, trust yourself. It's too easy to say, oh, maybe she's just having a bad day, or, oh, I don't want to invade her privacy, and just let things ride. But you're diagnosticians, you're clinicians, and we need you to trust your observations. And then what I recommend doing is check in with your colleague. Be familiar with resources that you can share with the colleague about whom you're concerned, and specifically address whatever concerns that person may have about seeking help. What's the best way to check in with a colleague? This can be awkward, but the best way is something as simple as, how are you? What's going on? And I recommend that you ask this simple question in a time and a space where you have some privacy and when you're both not rushing to complete a task. That may mean asking a fellow resident if they have 5 minutes to go for a walk, or 5 minutes to have a cup of coffee, or walk to the coffee cart. It may seem like those 5 minutes are impossible to find, but you're much more likely to have a meaningful conversation if you are not surrounded by other hospital personnel and other learners and other colleagues. And if someone recognizes that you're taking your most precious asset, which is time, to reach out. So start with a how are you? You may not get much information. The person who is in distress may say, I'm fine. And if that's the case and you feel there's something there, I recommend that you follow up with an observation. You say you're fine, but I'm asking really how you are because I noticed that you've been late for rounds each day for the past 7 days and that usually you're earlier on time. I'm asking because I noticed that you haven't been to the last several events where we've gotten together and you used to come all the time. I'm asking because I saw that you were really short-tempered with that medical student, and I know that's not like you. Present an observation. Do not judge. Do not share judgment. Just describe a behavior you witnessed that was of concern to you. If you're still not getting anywhere, it may be enough for today, for the time you're having the conversation, just to point out, well, I'm asking because I really care about you. And if you need to talk, I'm here, and there are other resources available. And we know from people who have recovered from episodes of depression, anxiety, burnout, and who have recovered from using substances and alcohol, that just knowing someone is there and someone cares can be truly, can be life-saving. I would suggest you ask, is it okay if I check in with you tomorrow, or may I send you a link to some resources? And then follow up as guided. When you are checking in with someone, if you have any concerns that he or she is thinking about or engaging in self-harm or thinking about suicide, please ask. Just as with our patients, there's no evidence to suggest that asking will give anybody the idea or will encourage suicide. And it can often be a truly wonderful opening for someone to express thoughts that they've had that have been tremendously isolating. You don't need to have all the answers. You do need to be able to listen. And listening can be your strongest tool. It can break down someone's isolation, someone's withdrawal. It can give someone the sense that you really care. I'd like for you all to take a break from this presentation. I found that video very powerful, and I hope that you did as well. In conclusion of this first part, we're going to get to more in the second part, but in conclusion, I want to emphasize that psychological distress is common among students, residents, and faculty and practicing physicians, that we need to think about psychological distress not as a personal failing or a personal weakness, but as something that we can address at the level of the institution, the level of the healthcare system, and that we can recognize, address, and prevent psychological distress with evidence-based strategies, and that resources are available. In the next module, we'll start off with some of those resources. If you have any questions, don't hesitate to contact the Office of Professional Wellbeing. You can also reach out to Dr. Barrett, the GME Wellness Initiatives Director, or to myself, and we would very much look forward to hearing from you. Thank you.